Thank you, Matt. Your job is done. And I want to say thank you to the former panelists. What an amazing way to sort of set the tone and help us think about how real the work we're doing is. It was really wonderful. So now we're moving into a panel focused on disparities and TBI outcomes. And I think this is a topic we all really embrace and see the highest priority in. In our initial conversations as a committee, I personally, I think can speak for all of us, we're kind of energized by having a really bold vision, which is reaching optimal treatment and care for everybody, all age groups, all locations, all backgrounds, civilian, military alike, for all people. And in order to do this, we need to advance diagnosis, treatment, rehabilitation, support systems, to be the state of the art and the best they can be, but we also need to think about systems in place to make sure that those advances are for everybody and people do have access to the information and the support and the care. So with that in mind, we have two amazing panelists. I don't think I have much more to introduce because I think we really want to hear what they have to say. So I will introduce both of them very briefly and then have just go from one to the other, and then we'll have some time also at the end for discussion and questions. So our first panelist is Dr. Richard Sidwell, who is a trauma surgeon at the Iowa Methodist Medical Center, a level 1 trauma center in Des Moines, Iowa, and he chairs the Rural Trauma Committee for the American College of Surgeons. Our next speaker is Dr. Megan Moore, who is the Sidney Miller Endowed Associate Professor in Direct Practice in the School of Social Work, and she's core faculty at the Harborview Injury Prevention Research Center at the University of Washington, where she co-directs the Injury-Related Health Equity Across the Lifespan program. And I forgot to introduce myself. I'm Corinne Fikesa, the Associate Dean for Research in the College of Public Health at the University of Iowa, and I am the William Battershell University Distinguished Chair at the University of Iowa. So with that, Rich, I'm delighted to turn over to you.
I will share my screen. And let's see, everybody should be able to see my screen. Does that seem right?
Yes, yep, we're good.
Okay, I can't see any of you. I've made it so that I've minimized my pictures so that it's not interfering with my slides. Thanks, and thanks for the invitation to be part of this, and a bigger thanks for including some consideration about the rural environment. So I don't have any disclosures about me personally for anything relevant to this, other than I'm going to tell you that I'm a true believer in what I have to say, and sometimes I get a little bit spun up because I'm on a soapbox. I was introduced as being a trauma surgeon at a level 1 center in Des Moines. And if you are in Iowa, this is as urban as Iowa gets. And so it'd be a legitimate question to ask, well, what do I know about the rural environment? Well, the answer is while I work at a major trauma center in a metropolitan area, that's not who I am. I'm not a city person. I'm a country person, and I live outside of the city. This is my town and my neighborhood, and no, that spot on my nose is not dirt. Rural is really what I'm about, and that's what I've made a big professional interest in my career. Before we even get started, it's nice to consider what do we mean when we're talking about rural? Because there are lots of definitions that can be used. And just for today, I want us to think about rural this way. Now, this is a slide. This comes from a course that I've been involved with called the Rural Trauma Team Development Course. And this is a course that helps with providing acute care to injured people, including brain injured people. And the definition of rural that we use in that course is this. It's when an optimal care is somehow delayed, and that delay can be because of weather or geography or distance or resources or experience. And so I want us to think about rural in these terms rather than rural being a specific population density or a specific geographic feature. And it's important, this is another slide from the Rural Trauma course, it's important because the burden of injury, and right now I'm talking about global injury, but I'll come to traumatic brain injury as well. The burden of injury is more heavily shouldered by those in the rural environments. And it's however you want to look at it, I want you to see this kind of 50% higher. Because kind of however we look at it, burden of injury, outcomes, survival, it's 50% worse being outside of urban areas. This highlights this a little bit more. So this is from MMWR a couple of years ago, and the lines here, the top line is outside of urban areas, and the dashed line is inside the urban areas. And if you just look at fatality rates from unintentional injury, it's again about 50% higher outside of urban areas. Well, it turns out that's true for traumatic brain injury as well. This is a nice colorful map, and this is looking at county level fatality rates from TBI. And in this map, red is bad. The more red you see means the higher fatality rate in that county. And I think you can just look at the map and you can kind of visually think that, okay, this seems to correlate with the rural areas across our country. Well, it turns out it does. When we overlay black onto the map, black is rural counties. And you can see it lines up perfectly that it's the rural counties that have higher fatality rate from TBI. Looking at the same information a little bit different graphically, left-hand side of this graph is urban areas. Right-hand side of the graph is rural areas. And this is showing the fatality rate for TBI, all TBI, unintentional, violent TBI. And I think you can appreciate it's about the 50% higher. If we just look at the unintentional, if you're in an urban area, it's roughly 10. If you're in a rural area, it's roughly 15. If we want to look at a specific subpopulation of kids, this is a fun review that is put together comparing outcomes from TBI in urban and rural areas. And watch this. Rural areas, it's higher rates of injury, lower GCS, meaning a more severe injury, more delays in getting to the higher levels of care, more unnecessary transfers between facilities, decreased access to specialist care, and higher costs. Like everything that can be bad is more common in the rural areas. Well, that leads me to kind of point number one that I want people to take home, and that is that outcome from TBI, and actually all injury, but TBI is worse in rural areas. Well, this is because there's a number of challenges. And I just want to present kind of some of the reality of living outside of urban areas. So one challenge is resources, obviously fewer people. If we think about the pre-hospital system of care, so once an injury has occurred, frequently those people are volunteers. There's less money, and I'm talking now public monies. So monies collected from tax levies. There's less money for system development, for community resources. And then there's this thing that I call the rural-urban paradox, and that is the people who live in the urban areas, the medical providers, they're the ones that have the most opportunity to practice their skills and maintain their skills. The providers who are in rural areas have the least opportunity, but also have the greatest distance and the greatest time that they're called on to actually use their skills. Rural areas have the inherent challenge of remoteness, and you can equate remoteness here with delay. Thinking just about the pre-hospital environment. So from the time an injury occurs until the time someone's able to get to the first hospital, there's all sorts of delay, finding people, getting help, mobilizing the help to the area. response time. All of these sources of delay end up worsening the person's outcome. And I'm going to highlight two different areas because I've traveled to a lot of rural hospitals across the country. And two of them in particular have really made an impact on me. So this is Winnemucca, Nevada. It is, I have over on the left side here, it is a long way from a higher level of care. It is along a major interstate. It's right along Interstate 80. And the hospital there, it's a very nice hospital with very good people there. But look, it's a small hospital, 25 beds. It has an average census of 8 people. It's covered by family physicians. And you can see they're a long way from a higher level of care. 165 miles to Reno, that is within range of a helicopter flight, but only with a stop for refueling before the flight. Another challenge of the rural system is simply the capability of the hospital itself. And this is extremely variable. So whereas an urban level 1 or level 2 trauma center has a very standardized capability, a rural center, be that a critical access hospital or the like, has very variable capability. And if you've never been to a small hospital, you may find it amusing that yes, there's plenty of places where you walk into the emergency room and there may not be somebody who greets you and you have to push the doorbell in order to gain entrance into the emergency room. Which brings me to another place that I was fortunate to visit in Van Horn, Texas. So Van Horn is a small town in far west Texas. And this is also a hospital that is along a major interstate highway, along Interstate 10. Now it's closer, it's 120 miles to El Paso, which is by Texas standards, fairly close. But this is a hospital that has 14 beds, and that's only if you count putting 2 people in a room. And the hospital is fully staffed by 2 nurse practitioners. And so this is what I mean about these small hospitals have a real variability in their capability. Well, anyway, when I take this information to the American College of Surgeons Rural Trauma Committee, everyone here feels like they've got some special knowledge, special interest in rural trauma care. But yet when I ask them, where do you work? Half of the room raises their hands and say they work in an urban level 1 center, and the other half of the room works at a level 2 trauma center. And there's not a single person in this room who actually knows what it's like being at a small center. Well, that creates a challenge because then the people who are trying to make a difference don't really have good information. And so we've worked on trying to find this out. I just present this again to drive home the point that these are very small facilities that we're taking care of. Most of them are less than 25 beds. It is uncommon for the providers at these facilities to have to take care of severely injured people. There is not surgical capability available. And look, almost half have to travel at least 75 miles in order to get to a higher level of care. So I think I've made my point there about the capability of the smaller hospitals. Then you add in the challenge of rural demographics. And in general, the people are older. And by less resource, I don't mean less money. I don't mean less income. What I really mean is less ability to use that income to help their healthcare. So there's a reluctance for them to want to be in the big city. It is harder to travel to get to the big city. It is difficult to get to appointments for follow-up. And so it's more difficult for them to use the resources. So anyway, summary point 2 is that there are a lot of inherent challenges that the rural areas face, especially when we're talking about a time-critical injury like a severe traumatic brain injury. John Armstrong's a surgeon, trauma surgeon in Florida, a really good guy. And I love that he says this because this is where I think that the opportunity really lies, is that a lot of our effort has been on individual hospitals. This report should look familiar. Here's the Zero Preventable Death report from 5 years ago. And this is trying to get at eliminating preventable death. Well, earlier I showed you a little bit out of this MMR report, and this is just one more thing. But if we were to look at preventable death, again, remember the number 50%. In the urban areas, preventable death is higher than in urban areas. And the Zero Preventable Death report, very good, 11 recommendations. And recommendation number 1 is we should be able to eliminate preventable deaths. And this drives me to my mist, the most important slide of the talk. And that is this. In this report of 490 pages, 531 if we're counting the index, the word rural comes up a grand total of 8 times. 2 of them in this particular sentence that highlight the system troubles that we have, that rural residents, it's uncommon for them to have access to a higher level of care. So that leads me to what if, and follow me on this, because this is where I think the real potential is for improving care in rural areas. What if? So what if there's an injury that occurs? And right away, there's some type of a notification system. And maybe it's a notification system that's technology, like our phone or wearable clothes or our cars that can notify. And while that notification is being done, whoever's around the area is able to help. And that notification system activates an EMS dispatch, a dispatch that has active online information about hospitals' capabilities. I've pulled these pictures out. This is from a call center in Little Rock, Arkansas, where the call center is able to know the status of all of the hospitals in the state, which then would allow the EMS to direct the patient to the nearest appropriate center. That center can work with the higher level of care. And it's not just a transfer. These are centers that know each other and work together and collaborate over the spectrum of care.
Rick, I'm going to let you know that you're at times as you wrap up your big vision for us.
I've got 1 minute. Thank you. Ultimately, all of this becomes the system of care. And when we have data, then we can make our system better. And that's where the real potential here is at. This has been legislated in the Mission Zero Act. It has not yet been funded, but it's through realizing the recommendation 1 from ZPD where I think our big opportunity is at. With that, I will stop my sharing.
Thank you so much, Rick. And you'll have more time to comment because we have a good amount of time for discussion.